everybody. It's 4 p.m. Italian time, so it's a time for food, for veins and veins for food. As always, we will welcome 30 seconds to allow everybody to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins and Veins for Food. Welcome for the last time, because this will be the, let's say, grand finale. So we thought about also presenting 10 surprises you will enjoy during the webinar. The first one is actually that you will finally meet in person, at least online, Monica Golovinsky. You might remember that along these 12 webinars, we have always started with the art and heart of Monica, dedicated to all the health professionals who have shown such a good heart during this tough COVID time, to which this educational project is dedicated in terms also of humanitarian support for the post-lockdown economic crisis, answering to a call of the prestigious Lancet Global Health Journal. Nothing would have been possible without a truly stellar faculty of world-renowned experts, friends and colleagues, and all the friends and colleagues who have joined along the way in this educational effort. I take this chance to deeply thank Professor Diaz and Professor Ramacciotti for having taken extra time during the last week to answer to all the previous webinar questions in whatever language. And I remind you that also today you will have the chance to answer to all these questions by these great experts, enjoying your answers in the educational platform of VWIN Foundation. Also, this week we'll provide international and national CME credits. And this year, this webinar, we have a grand finale in the lymphatic session. Indeed, lymphatics is a field that we really want to keep close to the venous field. And we are extremely proud to have with us today the major representative of the International Society of Lymphology, the person of the president and the president-elect. We will introduce them properly later on. And we are extremely honored to have them involved also in the future initiatives we will run toward Expo Dubai. Indeed, lymphedema, as we know, has been defined as a hidden epidemic requiring full attention. We know that we have millions of people affected by this still underdiagnosed and not always properly managed condition. It is a huge honor and also a personal pleasure for me to have Professor Lee, who also wrote a wonderful article I suggest you to read that is indeed entitled Phlebology and Lymphology, a Family Affair. You can find that in Phlebology Journal. Also for this reason, if you look at the acronym of VWIN, the word lymphatic is included together with the one of venous. I couldn't be more honored in having Professor Lee and also Professor Roxon, two giants of our field, who also contributed with extra educational recording material you can find in the platform. So I invite you to enjoy that, as I'm sure you will enjoy the precious final take-home messages they will provide, together also with the Professor Hussein. But not before having gathered with the continental expert representative important point of views and teachings, and we will introduce them one by one later on. Nothing would have been possible without this faculty, without individual donors, and without the magnificent 7 companies who supported the initiative by unrestricted grants. So thank you, Amno, Belton, Bayer, Medi, Servier, Sigvaris, and Tactile. I deeply thank all of you, and I look forward for being together for another food moment, this time not just for promoting education and humanitarian support, but also for the pleasure of being together again, and today virtually with a cake, a birthday cake in honor of our friends Valeria Guyard and Gustavo Barroso, who are celebrating just today their birthday. At this point, as always, I pass the mic to the colleagues I consider friends, of course colleagues, but first of all, family. So Oscar, the mic is to you.
Thank you, Sergio. Welcome everybody to the grand finale, the last edition of the wonderful Sunday webinars, which will certainly be another great opportunity to share science with the stellar experts from all over the world. Remember, you can make questions in any language either live or in the question and answer box. Recuerden, pueden hacer sus preguntas en vivo o en la casilla de mensajes. Por favor, no dejen de hacerla en esta última webinar y disfrútenla. Gracias.
Thank you so much, Professor Chi from California.
Good morning, friends. Good afternoon, friends, and good evening, friends, wherever you are. Please enjoy our last webinar for Food for Veins, but there will be surprise coming towards the end, and there are probably more to come. 各位同道们，大家早安、午安跟晚安。今天是我们最后一次的晚会，请大家珍惜这一次最后的晚会。如果有任何问题，请在我们的 Q&A 项，我们会尽快的和你回复。谢谢。
Thank you so much, Professor Chi, both for the 7 a.m. in the morning and also for the interaction with the Chinese friends and colleagues. As always, we start this educational initiative welcoming a guest of honor who is coming from a professional world that is outside the venous and lymphatic world, but that is involved no matter what with public health awareness. This is the grand finale, and we could not have a bigger honor than the one of having delegates from Expo Dubai. The Universal Expo is a once-in-a-lifetime opportunity to gather together with the world for a better future. This will happen in the unique venue of Dubai, a place where 2/3 of the world can fly in less than 8 hours. This will happen from October 21 to March 22, so 6 months in which 192 countries, so literally all the world, will be together looking forward for connecting minds, creating the future. I could not be more honored and thankful as Italian to the Italian pavilion, who of course is looking forward for a beauty that connects people, at the same time promoting at best health. What you're looking at over here is the Italian pavilion at the Expo, particularly the roof. You can see 3 boats as a roof. You can imagine what kind of architectural wonders we will enjoy while gathering together with the world, and I'm sure also your national pavilions will have similar wonders. And we are more than delighted and honored in presenting another surprise for this webinar, having the same Commissioner General of Italy for the Expo 2020 that will be held because of COVID postponement in 21-22, giving us his best wishes for our final webinar.
Dear all, I am Paolo Glisenti, Commissioner General for Italy to Expo 2020 Dubai, and I want to thank you for having me today as a guest of honor. It is a privilege, a real privilege for me to virtually meet with you, such a renowned community of medical experts dealing in a non-profit approach with the need of connecting know-how and skills for an healthier future and a safer society. Expo 2020 Dubai, postponed by 1 year due to COVID, looks like to be the first global event after the pandemic, and is appropriately named and titled Connecting Minds, Creating the Future. We are working hard every day with several participant countries, with research centers, with universities, Italian and from around the world, to present and showcase to the millions of attendees expected at Expo Dubai how an healthier and safer society can grow by strengthening and expanding multidisciplinary skills in a new intersectorial and intergenerational vision of sustainability. Italy intends to exploit the extraordinary opportunity provided by an holistic communication platform, such as the Universal Expo, for rising public health awareness on open source, open science, and open innovation ideas and values, the so-called One Health model. I really look forward to meeting you all in Dubai next year, and would be honored to host you in the Italian pavilion, which we named Beauty Connects People, in the spirit of our history and future of health, closely linked to wellness, lifestyle, and environmental security. See you all in Dubai. Thank you.
And with this, we deeply thank Dr. Glisenti and all the Expo Dubai Italian Pavilion. I'm sure this will be a unique opportunity to gather together in Dubai, in the Italian Pavilion, connecting our Freiburg lymphology minds for a better future also for our patients. Now we move toward the scientific part of the webinar. As always, we try to keep the atmosphere quite light, joking around the huge figures we have in our venous lymphatic ward, coupling them with a huge artistic or sport figure. So we will now introduce our first giant of the day. It's my huge honor to have with us International Society of Lymphology President, Professor Andrzej Czuba. He's coming from the University of Wrocław in Poland. And all the ones who have had the honor and pleasure to sharing in person the stage as I did with them, for sure will have noticed that he's for real a true gentleman. And since he's coming from Poland, I thought about Thomas Stanko, the great jazz player from Poland, as a metaphor. So Professor Czuba, the mic is yours.
Okay, I'm coming.
You can share your screen.
Okay. I'm trying to share.
And this is perfectly opening now.
Okay.
You're ready to go.
Okay, thank you, Sergio, and thank you for inviting me to this wonderful event. I'm really happy to join the faculty. And hello, everybody. I was asked to talk about lipedema management do's and don'ts. And okay, does it work? Okay, I have no disclosures here. What is lipedema? It is a chronic incurable disease that can have severe impact on quality of life, physical and psychosocial well-being. This is from best practice guidelines. But what it really is? Lipedema, as we believe, is known from ancient times. This is a well-known picture, Egyptian relief from the Hatshepsut temple. It is Eti, the Queen of Punt, with typical fat accumulation on arms and legs, which are characteristic for lipedema. So the disease is very old. Still, the disease is old, but it is not considered as registered diagnosis in ICD-9, so ICD-10. So we still don't have this disease in our register. However, in the new revision, 11th revision of the ICD, we have lipedema, which with the description that it is characterized by diffuse fatty swelling. And what is fatty swelling? It is difficult to describe. So, however, lipedema is very common, seems to be very common. According to some epidemiological studies, it is about 10 to 11% of women may suffer from lipedema. So it is not a rare disease. And we have many websites and many patients, organizations with lipedema in their names, even the websites promising cure for lipedema, which is interesting. So what is lipedema and how we diagnose lipedema? Well, in the nice book, nice chapter, Lipedema, the disease called fat, from the group of well-known experts, I got the statement that there is significant confusion under diagnosis of lipedema due to the lack of availability of laboratory genetic diagnosis and lack of familiarity and diagnostic criteria for lipedema. This is true. However, it is changing. Recently, Sandro Michelini and his group published a paper that they have discovered in family with lipedema, mutation of aldoketoreductase gene, and it's the first mutated gene found in the family with lipedema. So we are moving forward with the pathophysiology and as well as diagnosis. Lipedema, the term and the first description comes from Mayo Clinic and from Allen and Heinz, that describe the lipedema as a syndrome characterized by fat legs and orthostatic edema. And especially the second part of this description, the orthostatic edema, it's a little bit controversial. What are typical clinical features of lipedema? We see this woman with disproportional fat accumulation, especially in the lower part of the body, with spared feet, negative Stemerson, with so-called calf sign about the ankles. And in some women, arms are affected, and we have accumulation of fat in the upper arms. Key elements include this abnormal fat deposition and pain, significant, more or less pain of this fatty tissue. Majority of those women are obese, but not all of them. Some of these women have orthostatic edema. However, usually it is mild, but in some patients we see more pronounced orthostatic edema really, but it is not very common. What we see, and all the patients want to say, is lack of or minimal response to diet and exercise. Well, it is also controversial statement because both in our patients and from some centers, we see that there is sometimes good response to diet. And also psychological issues, lack of self-acceptance, are very important. The guidelines are differ from country to country, from society to society, as well as the description of lipedema. For instance, here we have guidelines of German Society of Phlebology from 2017, and edema is a significant part of diagnosis. Interestingly, in lymphedema, we don't see increase in fat in these guidelines, which is quite common. These are guidelines from Dutch Society, and Dutch guidelines include a lot of points and criteria of, basically from Volt. However, edema is not here. Also, from British guidelines, we see a lot of points. There is some edema, bruising, pain, and typical distribution of fat, with no history of cellulitis, which is characteristic for lymphedema. So, what are do's and don'ts? How we diagnose lipedema? The diagnosis is clinical, so we should use the typical features of lipedema to diagnose the disease, and we need thorough diagnostic workup to rule out systemic disorders, which, however, could be coexisting, like hypothyroidism and congestive heart failure. We should rule out lymphatic insufficiency. However, it is not easy because we do lymphoscintigraphy in all our patients with clinical features of lipedema, and we have found that probably 30 to 50% have some lymphatic abnormalities, and it was also published earlier by Forner Cordero. However, we shouldn't label with lipedema every patient with obese and lipohypertrophy characteristic for obesity. There is also statopedia, which is known from old times. We see here Hottentot woman, but also currently some of the models are quite hot, and they have this interesting fat distribution, which shouldn't be mixed with lipedema. Assessment. As probably for all our patients, lipedema patients need holistic health assessment. So we shouldn't focus on selected problems only like body shape. Here are some examples of advice how to assess the patient with lipedema. So other than history and physical examination, we specifically ask for pain, mobility, and gait. Psychosocial assessment is very important. Dietary assessment is also extremely important in this disorder. Also, we look at skin and vascular assessment and comorbidities. And Dutch guidelines include clinimetrics, so they ask to precisely measure all the features of lipedema patients, and which is probably very good if we want to monitor the therapy and our effects. So in the perometer or the tape measurements of the circumference mobility with goniometer, strength, pain with VAS. Unfortunately, we don't have better device, the better way to diagnose, to quantitate pain, fatigue, weight, and so on. So this is important that we, with assessment of our patients' lipedema, will have some measured points. For instance, well, abnormal gait is typical for women with lipedema, usually, especially because of fat accumulation on the inner side of thigh and incorrect leg axis loading, causing some development of vena valga. Quality of life is low for majority of women, and many of them suffer from depression. Quality of life inversely correlates with severity of symptoms. So what our treatment goals are? Well, like in many disorders, our goal is improvement of functioning, quality of life. And it can be done through reduction of pain, improving mobility, reduction of limb volume, reduction of body weight in overweight and obese patients, and the resolution of psychological issues. We always should discuss with the patient and the patient's expectations. We shouldn't promise permanent cure because until now it doesn't exist. We shouldn't promise great improvement in shape of their legs because it can happen only in some percentage of patients, but definitely not in all patients. And we shouldn't promise cure after liposuction. So treatment requires multidisciplinary approach. Physician specializes in lipedema, physiotherapies and occupational therapies, definitely dietitian, in many patients podiatrist, pain clinic in patients with more severe pain, treatment for concomitant condition, and for selected patients, especially with severe obesity, bariatric surgeon, and for some patients who are not happy with their legs and who do not respond to the conservative treatment, plastic surgery. Diet. It's controversial part. What we know, we should advise healthy, balanced diet, and it should be done by under supervision of dietitian. Many patients with lipedema have some eating disorders like bulimia, and they need psychological counseling. Bariatric surgery should be, for other patients, should be done in patients with BMI over 40. However, as we look through the web pages and patients advocates and some physicians, we can see that different diets are recommended for lipedema, especially ketogenic diet is very popular right now. Well, ketogenic diet for short term definitely works, but we don't have long-term data. We don't recommend also other restriction diet. And we shouldn't focus only on legs in patients who are obese. We should focus on obesity. One more slide about ketogenic low carbohydrate diet because it's becoming so popular. Last year, it was a published study in European Heart Journal showing that there's unfavorable association of overall and cause-specific mortality with low carbohydrate diet. It is a retrospective study, but from big cohorts, like enhanced. Also, the National Lipid Association of Great Britain expressed concern for ketogenic diet. Ketogenic diet is low in vitamins, especially vitamins B, magnesium, and iron, and it requires supplementation. And more long-term studies are necessary. We definitely see good short-term results. However, it should be definitely under supervision of dietitian and physician. Exercise. Well, definitely exercise is good for everybody, and we should advocate exercise program for all patients. Exercise in compression garment is probably better. I recommend it for all our patients. However, I'm not sure if there are studies on which compression and how what type of compression should be done for exercise. These patients usually don't exercise too much. So Dutch guidelines recommend graded exercise program, which is very wise to gradually increase the exercise load for lipedema patients. Aquatic exercise might be very good for all patients. However, we don't have good studies showing the effects. We shouldn't discourage any patients with lipedema from exercise. What are effects of exercise in lipedema? You can see a reduction of pain. You can see anti-inflammatory effect, also antidepressant action, improving mobility, and exercise obviously helps reduce weight. Many lipedema web pages and patients recommend exercise, which is very good. Conservative treatment includes compression garments, and we use compression garments. There's no clear difference. We don't know which are better, flat knitted or round knitted. However, we usually use flat knitted garments because of leg shape, and we couldn't get good round knitted garments for this disfigured legs. Compression garment should be used after liposuction in all patients. For how long? There's no clear guidelines. I advocate for minimum 12 months. Compression pumps, we advocate for patients with leg edema. For other, there's no good reason to do it. Manual lymphatic drainage is frequently advocated for, recommended for patients with lipedema. However, there are no good studies and no pathophysiological evidence that MLD might help, especially because we don't see impairment in lymphatic flow or clear edema in majority of those patients. It always feels good, however, but it's costly. So we do no harm with MLD, but well, it costs. This is one of our patients with lipedema in custom-made flat knitted garments. She feels better and exercise. Pharmacotherapy. There is no specific drug for lipedema. However, especially for patients who have significant bruising, we use flavonoids, and we use metformin for women with metabolic syndrome. Psychological and psychiatric problems are already mentioned, and recognition of need for emotional and psychological support is very important and crucial. So most of all patients should be consulted by psychologists. Liposuction. Well, these are guidelines from European consensus, lipedema consensus, these recent guidelines. We should consider liposuctions for women with symptoms persisting more than 12 months despite conservative treatment, in patients with functional disabilities, in patients with stable weight for at least 12 months. And preoperative psychological assessment is available and should be done. Also, another guidelines, German guidelines, written by plastic surgeons, advocate liposuction in patients with lipedema who are not morbidly obese, and morbid obesity should be addressed prior to liposuction, which is important. So, we should consider liposuction for patients unsatisfied with proper conservative therapy for sufficiently long time, like 12 months. We do not offer liposuction as an ultimate cure for lipedema because it's not. It shouldn't be the first-line treatment for lipedema. And we should offer liposuction for morbidly obese patients before we address obesity. And there are some references that I use. There are many guidelines on lipedema. And I would like to thank you.
And thank you so much, Andrei, for this wonderful presentation. Please stop sharing so we can now turn to our continental expert representatives. As you all know, we always welcome top experts from the different continents, and it's my true pleasure to introduce Isabella Loy from Salvati Foundation. So we are virtually flying all the way to Mexico for your first question. Isabel?
Thank you very much, Dr. Giamesini. And thank you for all this group of great conference that today we get to the end. Dr. Andres Suba, thank you for the presentations. I think everything is really very accurate. And I want to ask you a personal question. And I have right now a patient, a lipedema patient, especially that she started with a mild lipedema. They offered her the liposuction that in the shape of the leg, it was a great result, but the pain increased and increased really, stopping her to have a very good quality of life. So my question is, she's already been through the surgery for 5 months. We are having physical therapy with her. Obviously, she's in stockings, but the pain increased a lot and she barely can do her normal life. I would like to know what you think about that.
Well, I think it's a little bit unusual. So I haven't seen the patient, and because it's unusual, I probably would ask a neurologist to find out if there's maybe another reason for pain, because it should, all our patients who have liposuction have less pain. However, definitely we have some patients with very severe pain. And what I have done, after we ruled out all other reasons for pain, like spine disorders or different types of neuropathy, we need assessment. I used some unusual treatment that I used lidocaine infusion. It was described in some papers. It is not in any guidelines, but I use about 20 milligrams of lidocaine IV in slow infusion in hospital daily for about a week. And I did it not for many patients, probably about 10 or 15, but with very good and long-lasting result. But again, it is only for patients, for people that we ruled out any other reasons for pain, because it is a little bit unusual that the pain is increased after liposuction.
Thank you so much, Andrea, and thank you so much, Isabella. And now we fly on the way to the United States, thanks to Professor Bottini, who will introduce the next expert.
Thank you, Sergio. Let me introduce Andrea Brennan from Brennan School, Castle Smith in the USA. Andrea, go ahead.
Thank you very much. Good morning from Arizona, and I'd like to thank all of you for your time and efforts. And again, Sergio and Dr. Zuba, I appreciate your presentation. I'd like to share with you a thought about the do's and don'ts of manual lymphatic drainage. While well-established good clinical evidence is lacking, there is some evidence that MLD and compression together can mitigate oxidative stress and lipedema, especially when combined with low-frequency vibrotherapy and deep oscillation therapy. It has also been shown to have pain-relieving qualities for these patients, and it helps them with discomfort, tenderness, psychological, and sensitive issues. Decongestive lymphatic therapy modalities, which include manual lymphatic drainage and the exercises and so forth, have been shown to reduce pain, improve lymphatic function, decrease leakage from blood vessel, and lessen inflammation and fibrosis. With that being said, what are your thoughts of saying that MLD doesn't necessarily have the evidence and it just feels good?
I still think we don't have good evidence for this. We use MLD in our clinic, and we use it for, however, it takes a long time. We use it for some selected patients, and really for people who have more pain, sometimes it seems to be beneficial, but we try it sometimes, but I don't think there's a good evidence that MLD helps. Similarly, MLD in patients with lymphedema, with advanced lymphedema, we do, it was shown in many studies, that compression alone is as good as effect as CDT and compression for patient lymphedema, especially for advanced lymphedema. In lymphedema, I think we don't have sufficient evidence, and there is some evidence against. But maybe I'm wrong.
And thank you so much, Andrea. And now we fly all the way to my neighbor, Corrado Campisi, thanks to Willie, who will introduce him properly. Professor Chi, can you introduce him, please?
Yeah, so next we have a good friend of the VWin and from the University of Catania, Italy, Corrado Campisi.
Thank you. Thank you. It is a pleasure to be here. So Andrei, it was a beautiful and interesting presentation on lipedema. My question is regarding the lymphatic function in lipedema, because there is for sure low evidence regarding the use of standardized protocol for example, lymphoscintigraphy, studying patients with lipedema that could have also a mixed disease that could also appear as a lipolymphedema. We have published 2 papers recently. One was on analyzing a good amount of lymphoscintigraphies in which the lymphatic function was impaired, especially in the deep lymphatic system. So my question is, how do you think this could be standardized and applied in the treatment protocols for lipedema? And so in this way, the use also of the surgery, not only liposuction, that could also be performed with a lymph vessel sparing procedure in these patients, but also the importance of microsurgery in patients in which this lymphatic function is impaired, especially in the deep lymphatic system. Thank you.
Well, thank you. We also do lymphoscintigraphy. However, we didn't assess deep lymphatics, and we see some lymphatic abnormalities. And for me, it's still difficult to judge how important they are in development of lipedema. In terms of microsurgery, you are the expert, and I think we have to check this simply. In patients with significant lymphatic impairment and typical features of lipedema, but not lymphedema, as I have such a patient with spare foot, and in lymphoscintigraphy, we definitely see lymphatic insufficiency. So in those patients, lymphatic microsurgery definitely is worth to try, but we have to look at the results.
Thank you so much, Corrado and Andrei. And now it's my pleasure to remain in Italy for introducing Domenico Corda, another dear friend, and also author of a very interesting textbook that I really suggest you to enjoy. Domenico? Unmute yourself. Domenico?
Thank you, Sergio. Thank you very much. Dear Andrei, thank you for your very good presentation and above all, update presentation. You rightly did not place manual lymphatic drainage among the fundamental therapies of lipedema. I have rarely found edema in patients with pure lipedema, even those seen in the evening. Edema is present more often in lipedema patients with associated obesity. If you agree, can we say that in lipedema patients, generally, MLD and also lymphatic surgery are not necessary? Because the question is similar before, but I prescribed a lot of lymphoscintigraphy, and generally it is normal in the most part of lipedema patient.
So, I think you have partially answered your question already. What I say is, I think that lipedema is a complex syndrome, and we have many different patients. I do lymphoscintigraphy, as I said, in all our patients with lipedema, and probably 1/3 or more have some lymphatic problems, especially which be similar to lymphedema. For those patients, maybe lymphatic impairment might be corrected with surgery. I don't know, but majority of patients, probably definitely over 50%, have quite normal lymphoscintigraphy, and in those patients, I don't think they would benefit from any surgical procedures. In terms of obesity, well, obesity is significant. Majority of patients with lipedema are obese, and we definitely should address obesity first. How to do it, I don't know. I think we'll know more and more with other studies. For instance, I was impressed by the study from Sandro Michelini that I mentioned, that they found a genetic mutation of this progesterone aldolase. So this might point out about different direction in treatment. We thought about lymphatic insufficiency in lipedema for a long time. Maybe there is insufficiency that they couldn't detect. We know that the slow lymphatic flow promotes overgrowth of fatty tissue. So when we see overgrowth of fatty tissue, we think maybe the flow is too slow. But well, we couldn't find good evidence for this.
Clearly, this is an open discussion to be solved in the next chances we'll have, hopefully in person also. So now we move on the way to Japan. I wish I could introduce him because he has been fundamental in a teamwork we are developing between Latin America and also Asia, but it will be indeed Professor Bottini introducing the next speaker.
It's my pleasure to introduce Dr. Takashi Shamaki from Tokyo Women's Medical University Medical Center East in Japan. Dr. Shamaki, whenever you are ready.
Thank you very much for your kind introduction. I'm very interested, I'm very impressed your Dr. Tsuba's presentation. We know that lipedema is a chronic condition that is characterized by abnormal fat accumulation in the extremities, poorly understood disease biology, and lack of diagnostic tests may result in an underestimation of the disease. Many people with lipedema are obese or overweight, but normal weight individuals may be also affected. In my clinical practice, I have seen many female patients with swollen legs. However, I have never seen any patient who could fit in the lipedema category. In the previous study, in 60% of the patients suffering from lipedema, genetic background with familial predisposition has been described. So my question to you is, are there any genetic differences between Western and Eastern people, or did I just miss the diagnosis of lipedema?
Well, we don't, as you know, we don't know much about genetics. The first gene mutation was just described, and it was in Italian population. Well, we know that there are differences between Japanese, Chinese people and Caucasian people in genes. And we know that they suffer sometimes from the same diseases on different way. Well, definitely, Japanese diet is different, and you have less obesity than other populations. So maybe the obesity is triggering factor for clinical features of lipedema. So maybe we have this disease, but this is pronounced much less than in other populations. So we don't know, but we need to study this. When one of the problems with lipedema was lack of even clinical criteria, which are good for all the nations. Every country issued their own criteria. So even within the country, like in Germany, there are different groups suggesting different criteria for lipedema. So we have we have to good clinical diagnosis. Then we start to compare, and when we start to do genetic study.
Thank you so much, Andrea. And now we thank deeply all the Continental expert representatives who have been involved in this round. And now we give the mic to the audience. And we have received 16 questions, and it's no news for us to see that our Cleopatra of phlebology, Dr. Wassil Attar, is once again at the podium. And this is indeed the first question in terms of ranking. So the question for you is, a great lecture, Professor Tsuba. Since accumulation of fat deposition in a pattern that are small, walnut size or macronodules, this could give echonodular pattern by ultrasound defined as soap bubbles appearance. The question is, can ultrasound be diagnostic or even more importantly, a prognostic tool?
Well, I don't know.
Me neither.
Ultrasound, we do ultrasound in all our patients. Maybe better ultrasound tools, like maybe high frequency ultrasound probe, like 20,000 megahertz or more, might be something that will improve ultrasound diagnosis. In our practice, and I don't see much difference in patients with lipedema and in general in obesity. We can see sometimes this, we can see and we can feel this nodular pattern in those patients, but I don't think it is much difference between this pattern and something we call cellulite in obese women. So maybe we can find something, but for right now, I don't think it exists. So better ultrasound resolution, better technique, maybe you can see some more difference. But now I don't think it's something that you can use in practice.
And thank you so much, Andrea and Wassil. We now conclude this first part. I wish you could hear the hundreds and hundreds of people who are following us live in this moment. So a virtual clap to you. Thank you so much, and we look forward for being together in person soon. Now we move toward the second part of the webinar, and now I have to introduce a dear friend from Latin America, specifically from Argentina. So this time I had to choose another great music player, Andres Calamaro, who is a truly great player, as is a truly great professional, Professor Miguel Amore. It's truly our pleasure to co-work today with the International Society of Lymphology. Miguel will be the next president after Professor Tsuba. He's indeed coming from Buenos Aires University. And I have to say, I have always appreciated that he has always tried to teamwork at best with the phlebology world. I hope this is a path we will follow on all together. I asked him to talk about lymphedema, which and when drugs or surgery can help. And since we are having some technical issues from transmissions from his side, we will go with the recorded video and then we will enjoy him live for the question and answer. Khaled, please play the video. Khaled, here we are.
Thank you, Sergio, for this kind invitation to participate in this interesting project. I don't have any financial disclosure. I will talk about lymphedema and which and when drugs and or surgery can help. I will try to summarize this big topic in lymphology, showing some clinical cases. This classification in primary and secondary lymphedema may seem like a basic concept, but to make the choice of an appropriate therapy, it's necessary to be able to differentiate what type of lymphedema we have. Usually, secondary lymphedema have a better response to surgical treatment when they are approached in early stages. Regarding the stages, we use the proposal by the International Society of Lymphology, composed of 4 stages from 0 to 3. This is very important to speak the same language. We will not have the same response to a pharmacological or surgical treatment if we compare stage 0 to stage 3. In an advanced stage, the only therapeutic approach beyond rehabilitation, manual lymphatic drainage, or compression will be the Balkan surgery. And on the other hand, in early stage with non-sclerosing lymphatic vessel, microsurgery can be the choice as, for example, lymphatic venous anastomosis. But nowadays, primary preventive surgery is recommended. That means at the same time of the lymph node dissection, a lymphatic venous anastomosis can be performed to reduce the risk of developing a lymphedema. Professor Campisi and Bucardo create the lymph technique as the concept of primary prevention. And what about the images are very important, but not for the diagnosis. The diagnosis is based on the physical examination and only use images to have the information about what type of lymphedema we have and which will be the best option to treat it. You can see here different type of primary lymphedema with different condition. It means with different option to treat it. Today, with the advancement of technology, we can make a good selection of patients for an early intervention by comparing images. For example, this patient with that sign of edema is stage 0 and refers to a subclinical condition where the swelling of the limbs is not yet evident despite poor lymphatic drainage. This patient refers only pain on the hand and forearm with a history of resection of a lipoma in the left axilla. You can see the lymphoscintigraphy of this patient were not traced no dermal backflow. But when we apply IgG lymphography, we can see the dermal backflow at the level of the hand and forearm with the derivative pathway toward the cervical region. In this case, the most important to do is an early rehabilitation. This is another patient with the stage 0 after axillary lymph node dissection. 5 days after the surgery, a linear pattern was visualized near the hand, showing the anarchic pattern in the proximal region near the scar. It's an early sign of dermal backflow with a derivative pathway to the contralateral axilla by the mammary skin. But what happened in 30 days after the surgery? The linear pattern persisted with the presence of luminous area inside the lymphatic vessel due to the accumulation of the IgG by the disturbance of lymphangiomotricity. It's important, this concept, because these images can understand, when we can understand with these images, the concept of an early intervention is the gold standard to have better results. And regarding the fluorescent images, this technology is very sensitive to evaluate the lymphatic system, the progression and evolution of lymphedema with the different type of dermal backflow. You can see 3 types of dermal backflow: splash, stardust, and diffuse, and the linear pattern is the normal pattern. It's very, very interesting to do it. In this case, this is a lymphedema after breast cancer treatment with no evidence of functional lymphatic vessels, only dermal backflow with a stardust pattern with a derivative pathway towards the other axilla through the mammary skin. And what is the recommendation for this patient? Rehabilitation, MLD, compression, a vascular lymph node transfer. If we have functional lymphatic vessel in the arm, it could be an option, but we don't have it. Regarding primary lymphedema, it's important to describe it as a lymphatic malformation. And in that case, the lymphedema can be the top of the iceberg related to another condition. For example, in this year, with primary lymphedema and chylous ascites. Now, with a tissue sample, we can evaluate a panel of 23 genes to make a specific diagnosis. Here you can see different expression of lymphatic malformation. The first microcystic lymphatic malformation as a part of other vascular malformation. The picture of the middle, it's a Klippel-Trenaunay syndrome. with a lymphatic malformation 2, another vascular malformation, and the third is a primary lymphedema as a lymphatic malformation 2. Just let me make a little comment on the field of vascular malformation, including lymphatic malformation. We have a lot of new drugs, and appear this new concept of diagnostic, which means knowing the specific mutation of the gene and making a targeted therapy with a drug that modulate. I think that the gene therapy will be the future. Here is a patient with primary lymphedema, and ankylosing disease, and which is the best option to treat it. At first, nutritional treatment to reduce the callus formation and callus leak, and then we can reduce volume. And this is another patient with primary lymphedema and protein losing enteropathy. It's a Ballman disease, described by Ballman in 1962 as a primary lymphatic ectasia. And you can observe, we developed a capsule endoscopy to see this type of lesion inside the intestine. We studied this patient with fluorescent images with an stomach injection of the IgG before the surgery. But this is a part of the treatment that I will talk later. We gave to it also IgG mixed with cream before 12 hours before the surgery and during the surgery by an nasogastric tube. And then we performed a laparoscopic surgery with fluorescent images, and we saw the obstruction of the intestinal lymphatic, a dilated and obstructed lymphatic vessel with a callus leak. You can see here a segmental part of the wall of the intestine with a fibrinotic area. And here you can see the chyliflorous vessels with any fluorescent dye inside the vessel because they are obstructed. And as a palliative treatment of this patient, we take a flap of the omentum to develop the lymphatic omentum transplant to the groin. For that reason, we inject at the beginning, inject IgG into the stomach to select the best flap to transplant. We must remember that this is a palliative treatment because the patient continue with the clinical treatment, with nutrition, with the compression, with the MLD. Just we develop as a palliative treatment to treat it or to improve the primary lymphedema regarding this pathology. But we must remember that it's a malformation, just to improve the lymphedema of the lower limbs. And we develop this type of surgery, omentum lymphatic transplant. And you can see the picture before and after, but we must remember that it's a palliative treatment. And regarding the pharmacological treatment, and more specific in lymphedema with effects of targeting inflammation, some research show beneficial effect with oral doses of ketoprofen, reducing the edema and decrease the skin thickness. Or in the case of this young lady, a patient who underwent a treatment with topical tacrolimus just in early stages with good response too. In some centers prefer the use of another type of drugs as benzopyrene, like coumarin, because increase the macrophage activity, encoding the lysis of protein and reducing the formation of fibrotic tissue. And in this type of cases, we can add a benoactive drug because combine venous hypertension and lymphedema. And we test the lymphatic imbalance or damage after venous hypertension of the lymphatic system. This patient may combine two damage, the venous hypertension and the damage after stripping of the great saphenous vein. As you can see here, an oil lymphorrhaphy of this patient with dilated lymph vessel and some aneurysm. You can see here two types of venous hypertension, the chronic venous disease and Klippel-Trenaunay syndrome, and we test the lymphatic imbalance in this patient. They don't have a lymphedema as a clinical condition, but have a lymphatic imbalance. You can see the dermal backflow with a linear pattern after that compensated the area. For that reason, we add a compression, of course, and venoactive drug to have this type of patient. And in cases of patient with lymphedema, with the evolution, the lymphedema can increase the fibrosis and the fat tissue without response with MLD. And for that reason, it will be possible to perform a liposuction to remove the fat tissue and fibrosis, or maybe the correct term can be lymphoaspiration as proposed by Corrado Campisi. This is another type of patient. We perform a liposuction on the foot to let this patient use a normal shoe. We have different patients, but it's are interesting to show. And this is the case of lymphatic venous anastomosis. Yeah, as I mentioned before, this type of surgery can be performed only in early stages with functional lymphatic vessels. We have different technique, different proposal. Professor Campisi here in the panel is a pioneer of lymphatic microsurgery, and he can explain more about that with his own technique too. Some time ago, we incorporated the term super microsurgery. It's a type of microsurgery with different size of vessels and other instrumental technique. Another type of lymphatic venous anastomosis is the lymph node venous shunt. It was proposed by Professor Olszewski from Poland in the 60s. It's an interesting surgery too. He proposed recently another type of surgery for obstructive lymphedema. It's the silicone tubes, in the implanted silicone tubes too. And what about the vascularized lymph node transfer? We can select this technique in some cases for primary lymphedema or after lymph node dissection. This is the cases of the picture in primary lymphedema. Maybe in the near future, in order to improve the connection between the flap and the lymphatic of the arm, we could apply inside the flap a VEGF factor. This will be an option in lymphedema after breast cancer, but some warn about the use of growth factor and the risk of develop metastasis. Other groups are using collagen scaffold to improve the connection of the flap and the lymphatic without the use of growth factor. And finally, this interesting surgery is the Balkan surgery in special cases after rehabilitation, MLD, compression. In that case, we need to restore the morphology of the legs. You can see another patient, or in this type of patient with a lipolymphedema, with increase of fat tissue. It's combined with lymphedema and fat tissue too. Thank you very much.
And thank you so much to Professor Amore. Please can I stop sharing so I can share my screen and welcome the next round of Continental Expert Representative. I will just take this chance. I told you before, we will have multiple surprises during this webinar. One was actually a difficulty as a surprise for us because at the very last moment, unfortunately, Professor Milic was not able to come. But at the same time, this difficulty became an opportunity to measure once again the niceness and professionalism of a dear friend that is testifying teamwork among friends and colleagues, Professor Narayana. So we'll substitute him later on. And the second surprise is that finally we will meet in person Monica Golovinsky, that is not just an outstanding painter, but also a wonderful art professional. But we will start in alphabetical order. with Professor Mabel Bussati. She is the past president of the Argentinian College of Venous and Lymphatic Surgery, and it's my true pleasure to welcome her with her question. Mabel?
Thank you, Sergio. I really thank Dr. Gianesini for invitation to participate in this webinar. Congratulations, Dr. Amore, for your presentation. Recent studies in the USA indicate that chronic venous insufficiency is the main cause of secondary lymphedema. It affects 5% of the population, 16 million in the USA, according to DIAN in 2020. Venous insufficiency leads to lymphatic overload and permanent damage on a substrate of chronic inflammation. What role will the inactive drugs play in the general treatment of secondary lymphedema, based on your experience? Thank you very much.
Thank you, Mabel. I made a short comment about drugs in the presentation, because some of them don't have a real evidence to have a potential beneficial effect to treat lymphedema. Nevertheless, I mentioned benzopyron as alpha-benzopyrons as coumarin, because some centers around the world are using coumarin. Focuses on the proteolytic effect to treat the fibrosis of the tissue. In case of gamma benzopyrons, as flavonoids or diosmin, we use
Miguel? So we are losing Miguel. So, Khaled, do we have any connection issue? If Miguel can listen to us, we suggest to switch off the camera. And since we have the opportunity of a second keynote speaker, we will ask kindly to Professor Tsuba to come into the answer about venous active drugs and lymphedema. So, Andrew, can you please complete the question?
Hello? Yes.
Yes.
Sorry for the active drugs have. Yes, Miguel is here.
Miguel?
Yes.
So please.
Yes. Okay. Suba. Andre?
Okay.
Miguel, if you have connection, please speak.
Yes, it's okay. Thank you. I mentioned that I made a short comment in the presentation about drugs, because some of them don't have a really evidence that to have a potential beneficial effect to treat lymphedema. Nevertheless, I mentioned the benzopyron as an alpha-benzopyryl coumarin, because some centers around the world are using in case of to reduce the fibrotic tissue as a proteolytic effect of the as coumarin. In some cases of gamma benzopyron as a flavonoid or diosmin, we can use it in patient combine a venous hypertension. As you can see, that's the patient that I show when combine lymphedema and venous hypertension. In that case, it's really a beneficial effect. But in other patients, I don't use it.
Okay, thank you so much. And now we fly all the way to Italy for another giant of the field. So I will ask Professor Bottini to properly introduce him. Oscar?
Let me introduce Professor Corradino Campisi, past president of the International Society of Lymphology. Corradino, pleasure to see you again.
Professor Campisi, Corradino, can you unmute yourself and switch on the camera? Okay, here we go.
I have enjoyed, dear Miguel, your all-round and complete presentation. As far as surgical options are concerned, I would like to underline the very important role, above all, of the lymphatic microsurgery in the therapeutic strategy of lymphedema, according to the stage of each case, without neglecting the anatomofunctional and surgical key factor of deep lymphatic vessels to obtain the best long-term results. This is the long experience of Genoa Center, as you know. What is your opinion about? In addition, what do you think about the necessity of a close integration between drugs, complex physiotherapy, and surgery to win lymphedema progression and consequent life-threatening worsening? As a matter of fact, a lot of non-surgeons colleagues up to today in their clinical practice shown to be lastingly against surgery, discouraging patients to trust lymphatic surgeon and assuming in this way an incomprehensible position considering the relevant international EBM literature of lymphatic surgery in comparison with medical physical so-called conservative procedure, which have, without surgery, only a symptomatic role. According to my opinion, this is really a key endpoint of our comparison.
Thank you, Professor Campisi. Just I tried to underline on my presentation the important role of an early intervention. And for that reason, the surgery can be the better option, like a microsurgery and lymphatic venous anastomosis that you propose. I think that it would be a very good option in early stages. Of course, if you combine, because the surgery, it's not only the solution, we must combine with CDG, with drugs in specific cases. But the most important to underline to treat in early stages. Thank you, Professor Campisi.
And thank you so much. Now I wish I could introduce her because I'm in depth with her because we used one of her wonderful paintings at the beginning of every webinar, but I will introduce her just as a wonderful painter and a wonderful person. She also exposed at Guggenheim, but for the health professional part, it will be Professor Chi introducing her. So we fly now to US, Willie.
Yeah, thank you for the honor. Now we have a name that is very familiar to all of us, who we see her face in painting every single one of our webinar, Dr. Monica Glowicki, who's a good friend of the VM Foundation. She comes from the American Venous Forum and the Mayo Clinic. Monica?
Unmute yourself, Monica.
Thank you very much. Thank you, Dr. Giannesini, and thank you the whole team for your kind invitation. I'm deeply honored, I have to say, and doubled honored because of the painting and recognition of the Rochester Art Center initiative to honor the frontline workers in Rochester. So it's really, really pleasure, and I'm very humble. And I thank you again. So now coming to the lecture of Professor Amor, I would like to congratulate him because it's truly a show of his extremely vast experience in this challenging and debilitating disease. I would have some question about the drug therapy. I leave the surgery question more to the people who are really hand-on surgical techniques. My question is, first question about the antibiotherapy indications. and specifically the indications and recommendation for preventive antibiotics in lymphedema. And my second question would be concerning the micronized purified flavonoid fraction. As you all know, I worked for many, many years in research concerning that drug and the other similar components. And we had several studies, the animal studies and the studies in post-mastectomy lymphedema, showing the improvement as well, clinical, as well the lymphoscintigraphy improvement after the MPFF treatment. So I would like to ask, and especially in the rise of the renewed interest for this kind of drug, if truly Professor Amor think that there is maybe a pattern to develop a new treatment for lymphedema.
Thank you, Monica. Miguel?
Thank you, Professor Glowinski. Just in the first question, we use Sana-specific antibiotic as prevention in case of erysipelas to try into this typical infection in this patient, and we use antibiotic in case of surgery. But I think that is the answer for this, the first question. And the second question, I think that I base part of my conference in the last consensus document of the International Society of Lymphology. And as I mentioned, relating some drugs, we must wait more evidence to use it in this type of patient. Nevertheless, in some centers use it a lot as a flavonoid. I think that I show some patient, and I think that's the best option in that type of patient when combined venous hypertension, like a chronic venous disease. Thank you.
Thank you so much. And now it's my deep pleasure to fly all the way to Asia. I have to say that I know few colleagues who can participate in such a professional way to all the webinars of ours covering whatever topic. And I actually know no one so good in squash. Indeed, is also my squash master, and I truly miss the nice time we had together in the last meetings. So it's my pleasure to introduce Professor Narayan Sriram. Ram?
Thank you, Sergio. And thank you again, Sergio, Willie, and Oscar for bringing together this superb initiative. My question is to Amor and to Andre as well. Firstly, congratulations to both of you for some extraordinary work. My question comes to you based on my experience about extracorporeal shockwave therapy or low-intensity ultrasonic therapy. And I don't know if you all have any information on this. And this comes by accident because it has been used for cellulite therapy in the cosmetic world. And then in patients whose swelling wouldn't go down after venous surgery, we tried a couple, either after stenting or superficial surgery, and surprisingly, the edema began to resolve. And then we had a couple of patients who have genuine lipedema, so no venous incompetence, and lymphoscintigraphy is normal with very early lymphedema. And again, we started finding some success, especially in Asia, where the lipedema is not so bad, but the shape of the leg seems to be of a huge cosmetic importance in this part of the world. So I was just wondering, we seem to be finding that at least in early cases with not severe lymphatic or lipedema, there appears to be some positive results with low intensity shockwave therapy, with ultrasound shockwave therapy. Do either of you have any experience or any opinions on this?
So we will give the question just to Miguel because we are running out of time, and I'm sure Andre can comment later on in written form. So sorry, Professor Tsuba, but we really need to keep the time. So Professor Amore?
Yes, just I don't have any experience with the technique that you mentioned, but would be a possible treatment in the future, but I don't know.
Okay, so quick one to Professor Tsuba then. Do you have any experience, Andrea, about this technique? Unmute yourself, please. Unmute yourself. Okay.
I personally don't have any experience with this. I think Franz Josef Szingale might have some good experience. He is the best.
So thank you so much for burning the next introduction, Professor Tsuba. But jokes aside, thank you so much. And now we give the mic to Professor Bottini to introduce for a second time, indeed, the expert we already named. Oscar, unmute yourself. Great.
Yes. It's my pleasure to introduce Dr. Franz Szingale, one of the biggest experts in the world about lymphatics.
Thank you. It's a really nice conference, and thank you so much for inviting me. So it's not so easy for the two speakers just to give a whole overview of the illness, especially Professor Amore is talking about lymphedema. So it's more about surgery, and as you know, I'm more involved in conservative treatment, but we changed our opinion now. And I think that surgery is going on in lymphedema, but we have only poor results. So about 30% of our patients, they get in a better stage after lymphovenous anastomosis or even after lymph node transplantation. 60% are in the same and 10% are worse. So Professor Moore, what is your long-time or long-term results? Do you see really that those surgeries are going on to take the patient in a good shape without any conservative treatment? We combine it after surgery, after LVA, so all our patients go on for compression. Without compression, there is no use. That's what our experience is. But even with this compression, so 60% of them, they get back again in the first stage, and 10% are worse. Only 30% get better. So what are your results?
Again?
Thank you. Yes, I think that's all type of surgical technique. If you don't combine with the CDT, with the rehabilitation after and before the treatment, we don't have a good response of that patient. I think that rehabilitation, the CDT, is the most important. It's the top of the treatment in all type of lymphedema. I never think to develop a surgery, lymphatic venous anastomosis or other type of surgery without CDT before and after the treatment. I talk with the patient. The solution, the final solution, is not the surgery. It's very, very important to remark this, because all patients come with us to resolve the problem, and okay, make the surgery, and that's all. It's not the solution. The solution is continue with the CDT after and before the surgery. Of course, if you select a correct patient with images, with different things in early stages, it's we will have a very successful results.
Thank you so much, Miguel. And now, deeply thank to all the Continental expert representatives involved in this session. We give the mic now to the audience, but in reality, we give the mic to a giant, because the first question in terms of ranking is coming directly from Professor Glowinski Peter, we know, editor of JVS, and he is asking you, which of the many surgical procedures would you recommend for a prospective randomized study to compare with compression therapy we all should support? And I truly appreciate such a big vascular surgeon is looking forward also for lymphatics. So which procedure to be compared with compression in a RCT, in your opinion, Miguel?
It's a very good question, because I think that you can compare compression with any type of surgery, because the compression is the basis of also CDT to treat this type of patient. But if you perform in secondary lymphedema, or you perform preventive prevention technique, like I mentioned, lymph technique, in early stages, in the same time at lymph node dissection, we will have a better results. I think that we can compare the compression because it's important after and before the treatment. Of course, it depends the type of surgery, but in case of lymphatic anastomosis, we must wait to develop a compression, but we need to add CDT and compression therapy in all type of patients.
Thank you so much. Thank you so much, Miguel, and thank you so much again to all this part of the webinar faculty. Now we turn toward the real final end, so we take also some extra minutes for the final goodbyes, but not before having enjoyed the take-home messages from the huge honorary chairs, starting from Professor Hussein from Ain Shams University in Egypt. Ahmad, unmute yourself. Great, yes. You're here.
Thank you, Sergio. I'm overwhelmed. This webinar has been so enriching, and both distinguished speakers, Dr. Amore and Dr. Zuba, they touched base on several aspects of the lymphedema and lipedema, but quickly I would be quite interested to give some quick comments and take-home messages. First of all, I think we should all humbly embrace a few concepts. Currently, there is no radical cure for lymphedema, according to the best practice guidelines. And then I'll make an appeal to the International Society of Lymphology about that, of course. But lymphedema, the goal of managing the lymphedema is primarily to reduce the severity of symptoms by diminishing to variable extents the volume of the lymph and allowing a slightly better quality of life to the patient. There is no single modality of treatment that is sufficient alone. There are several modalities and they are complementary. They are not interchangeable. Peter Glovitsky a few minutes ago raised the probably the issue of having a good CRT comparing compression to one of the modalities of treatment. And I know he's referring to surgical modalities. However, we are still far from having a well-designed CRT for that. Lymphedema patients are often miserable. We have primary lymphedema and secondary lymphedema, and the natural course and clinical history is clinical course and natural history are not quite the same. So we have in hand right now, to sum up, manual lymphatic drainage, which should be given an opportunity of like 6 weeks daily under a good specialist supervision, and then self-education the patient so that he can be doing it at home with the help of a close family relative. Of course, we have compression garments and plastic stockings. We have exercises, again, that might help. Then come the role of drugs, limited value, probably. We have the benzopyrones, like coumarin and not coumadin, that can hydrolyze the protein and the protein-rich fluid. And then we have care of the skin, and we have other drugs like the venotonics, again, of limited value. Diuretics did not prove to be of sustained value, of course, interrupted courses sometimes. Now, the most important is and then finally the surgery. We have the bulking surgery and the physiologic surgery. We have, like 27 years ago, we have published our own, at the time, pioneer experience in this kind of physiologic surgery, excuse me, 17 patients at the time, but we had, of the lymph node venous anastomosis at the time, an unacceptably high recurrence rate at 12 months, like 35 to 38%. Then, of course, I met the two giants who are in the panel right now, Professors Corradino Campisi and Professor Bibi Lee, who were in a position to become my own mentors and then masters in that time. So as far as the surgery, debulking surgery probably is quite evident to the patient, because the patient with the lymphatico-venous or the lymphatico-lymphatic anastomosis needs other complementary modalities like compression and then massage, manual lymphatic drainage, and exercise. So, and I know that Professor Campisi is doing that in his excellent center, and I've been sending him over one of my patients, and I'm aware of the marvelous outcome of that using all the modalities. My final comment is for the International Society of Lymphology. Probably we need some dedicated research teams to improve our knowledge on the lymphodynamics as well as the molecular and genetic basis of the whole process. But after all, this was quite educational, and I thank all the distinguished members of the panel. Thank you.
It's me and Olavi Wien deeply thanking you, Ahmad, also for a perfect corner kick, because indeed this final webinar was dedicated to a potential teamwork between venous and the lymphatics. I truly hope this will be another step forward in collaborating between our phlebology and the lymphology world. And this is a perfect timing indeed to introduce Professor Bibi Lee from George Washington University. Is indeed the man that has been putting together venous and lymphatics in such a bright way. We are having some surprises for today, as I was saying. We have 15 extra minutes. We are used in Italy to have 15 academic minutes, we would say. That's a tradition we have over here. So we will enjoy 15 final minutes with Professor Bibi Lee and Professor Roxon, starting from Professor Bibi Lee. So Bibi, the mic is yours. Can you unmute yourself? Bibi? Yes, unmute yourself. Perfect. I will
Thank you
share.
very much, Sergio, to introduce me. I like to share 3 slides to summarize what I really wanted to share with you. First, I would like to thank the organizer once again to invite Dr. Shu and Amore, to world-renowned authority in the field of lymphedema, to share their invaluable experience through the keynote lectures. So I don't have much to add other than the compliment to their contribution, but I humbly wish to remind you of the fundamental questions to remain to be answered on both lipedema and lymphedema altogether, on its perspective for the future as following. First, lipedema we used to call long neglected cousin of lymphedema. But we have to remember that we have to provide our answer for these 4 issues here. Number 1, how much do we know about the pathophysiology of lipedema, especially fat metabolism? Number 2, how much we don't know about the pathophysiology of the lipedema. Number 3, how much we should know more about the pathophysiology of lipedema so that we could understand better on the relationship between lymphedema and the lipedema. Lastly, how much and when all this fantastic suggestion of surgical and the surgical approach to be accommodated to improve the condition of lipedema. After all, for lymphedema, we have to clarify how to imply the right choice of the therapy at the right time. Number 1, can we keep the patient with a complex decongestive therapy as the permanent solution? We should not confuse the people with this CDT-based therapy without telling them the limitation of this management. Number 2, how much the infection or sepsis should be involved to the advanced care, including surgical therapy. I still don't have the answer for that to clarify to the patient. Number 3, how long the patient should remain on non-surgical conservative management like ZDT based on the compassion therapy before the consideration of the surgical therapy. Lastly, which kind of reconstructive surgery with or without ablative or excisional surgery combined? Criteria of the indication, how to choose. I spent more than 3 decades to learn first from Waldemar Olszewski more than 4 decades ago. I still keep asking to myself on these fundamental issues, and I wish you all keep in mind to deliver some future prospect in the future. Thank you, Sergio.
Thank you so much to you, Professor Lee. You really make us feeling like we are walking on the shoulders of a giant that you are indeed. And another giant, and this will be the big finale, and this is another surprise, is a brief lecture from a huge expert, Professor Stanley Roxon from Stanford University. So now we will pass the mic to him with all our gratitude for this final lecture on Food for Veins webinars. Thank you so much, Stan.
Thank you so much, Sergio. I'm just sharing my screen. Let me see if I can.
Perfect. We can see it nicely and hear you nicely.
Wonderful. Well, I want to express my thanks for this event, for the invitation, Sergio. I'd like to also express my gratitude to both Andre and Miguel, who are colleagues and friends. Wonderful presentations. And most of all, I'd like to say thank you for the opportunity to just present a little bit of our, I might call it late-breaking research. I'm going to just spend 5 minutes talking about the material that we've just published in a translational investigation published in the Journal of Clinical Investigation Insight. And it, I hope, will shed a little bit of light on some of the discussion that has preceded about lipedema and specifically about its pathophysiology. So as Andre shared so eloquently earlier this morning, these 3 diseases have certain phenotypic similarities: lipedema, lymphedema, and what we might call lifestyle-induced obesity to distinguish it from lipedema. There are clinical characteristics that distinguish them, but of course clinicians remain often quite confused about which is which, or when there is overlap between one and another. And of course this poses tremendous challenges both in diagnosis and treatment. So the issues with lipedema, and I'm just going to reiterate some of the concepts that have already been shared today. The issues with lipedema are, number one, while it is quite a vexing presentation, it is a diagnosis that currently rests purely on clinical grounds. There are no characteristic or reproducible imaging attributes, although we've heard that at times there may be some findings that may be helpful. There are no historically identified biomarkers for this disease. And even histopathology, with the little bit that is available, is really not available. We've made progress in other aspects of the lymphatic disease. I'm happy to say that in lymphedema in recent years, we've been able to identify distinct molecular pathways that are upregulated in the tissues of lymphedema, and these have in fact led to the identification of significant molecular biomarkers for the disease. But historically, we've lacked this for lipedema. So what I'd like to share this morning is what I believe to be the first biomarker for lipedema that we have identified recently, and specifically that helps to place lipedema squarely within the realm of a lymphatic disorder. So we relied upon the ability to isolate from blood, from body fluids, these compartments called exosomes that are initially generated by the cellular content of tissues and allow for packaging of cargoes of protein, of lipids, of RNA products of a variety of sorts, and of DNA itself. And in this case, we were using it to identify very small concentrations of proteins of interest that might be circulating in the blood that might elude our ability to detect just by looking at the proteins themselves as they circulate. This is a graphical representation of the work that we attempted to undertake. We started with some mouse models and then used the predictions from the mouse models to investigate human disease. We isolated exosomes from plasma, both from the mice and from the human subjects. We initially performed mass spectrometry on the protein fraction from the exosomes, identified the proteins of interest, which we then validated with ELISA. Now, again, we're interested in this question of lymphatic disease versus obesity. And so in the mouse setting, we decided to look at 3 subtypes of mice. The wild type mice, of course, is the normal one. A PROX1 heterozygote is a mouse in which, because of this perturbation in the signaling related to lymphatic endothelial cells, they are born as young mice that look phenotypically normal. If you look at their lymphatics under the microscope, they're not normal. And with time, these mice develop age-dependent obesity, but it seems to be based on a lymphatic substrate. We looked at another genetic variant, the OB mouse, which is predisposed genetically to obesity, but does not have any identified lymphatic abnormalities. In the human setting, we compared normal subjects to those with secondary or acquired lymphedema, with lymphovascular disease, which we linked together both the primary lymphodemas and lymphatic vascular malformations, and patients with lipedema clinically diagnosed. So this is the summary of the proteomic work that we did in the mice. And initially, we had an analysis of the OB mice that we could then compare with the PROX1 heterozygote. And what we see here is that when we compare, there are some shared genes, a very few number, but there are 61, sorry, I said genes, I mean proteins, 61 proteins that are upregulated in the PROX situation and 34 downregulated. When we looked at that in greater detail, you can see here in red, these are the proteins that are specifically up and down regulated in obesity versus the larger number that are up and down regulated in the PROX1 heterozygote. Again, this animal has a lymphatic abnormality with associated obesity. We took this information and then took it into the clinical arena. We studied, this is basically a pilot investigation, but a reasonable number of patients divided into these 4 categories. And you can see here their clinical attributes, which I won't dwell on at this point. But I want to share with you the fact that of that list of proteins that we determined in the PROX1 heterozygote, there was one that stood out as having a cross relevance to the clinical situation, and that was so-called platelet factor 4 or PF4. And we were very gratified to see that when we looked at this critically, there was a 90% specificity for the association with all 3 of the disorders, putatively lipedema being a lymphatic disorder as well, as compared to the normal subjects. And in the case of lipedema, the sensitivity approached a clinically relevant value as well, and we believe would approach a clinically relevant value if we had a sufficient number of subjects to investigate. So this is an ROC looking at the relationship between specificity and sensitivity for this particular marker. So this is platelet factor 4 as seen by X-ray crystallography. Just to introduce those of you who don't know it, what it is a chemokine released from alpha granules of platelets. It promotes blood coagulation and plays a role in wound repair and inflammation. It inhibits angiogenesis and is chemotactic for neutrophils, fibroblasts, and monocytes. Now, because of the concern of the relationship with platelets, there is, of course, the concern that what we're looking at is the effect of comorbidity. So we carefully examined the roughly 60 patients that we enrolled in this study and to identify if there were any significant patterns of comorbidity, of which there were none, and specifically none of these patients had any coagulation defects. We believe that PF4 plays a role in lymphatic disease through its activity with angiogenesis and its activity in chemotaxis. the inflammatory substrate and the fibroblastic based scarring process that is associated with these diseases. The theory here, of course, is that since lipedema does appear to share this attribute with the other lymphatic diseases, that the pathogenesis of lipedema is in fact a primary lymphatic microvascular malformation that leads to edema of the adipose cells themselves, allows them to undergo the hyperplasia and hypertrophy that characterizes the disease. The implication for this is not only do we now have theoretically a diagnostic marker that will help us at least to distinguish lipedema from obesity, but the broader context is that there's a growing sense that lymphatics play a role in a broad array of systemic diseases. I've long been an advocate of thinking about the lymphatics as playing a major role in systemic morbidity and mortality. And now we have a marker to potentially look for some of those roles. I'd like to conclude and just take 1 minute of solicited time to help the audience understand that in this pandemic era, which has, of course, allowed for this webinar series to occur, we're aware that many of our lymphatic-specific clinical meetings have been canceled or postponed. So I want to make everyone aware that in October of this year, sponsored by Stanford University, we will be holding an international virtual symposium to go over some of the topics that are very lymphatic disease specific. And here you have the website where you can enroll. This will be a CME accredited program for those that need that or desire it, with a very nominal cost. These will be 2 half-day virtual symposiums on a Friday and a Saturday, and open to all that might be interested. So Sergio, thanks once again for the opportunity to present this information.
So Stan, it's me having issues in finding the right words to really congratulate and express our gratitude for the outstanding academic work you're doing in the lymphatic field. I've always appreciated that so much, that in a field in which also BMJ recently published, there is not enough attention toward the evidence-based data, for which if we don't standardize data, we don't even know if CDP is working or not. You have always been an example of academic approach to the field, and I really congratulate and thank you once again. We finished our 15 academic minutes, as we usually do in Italy. We also say in Italy that every room has its own exception. So we should go on with the 4 minutes left to give you the last surprises. But since every rule has its own exception, I will make an exception because Professor Sriram Narayan just asked me to make a question to you. And since we have the huge honor of having you here, Ram, please, let's make the exception and make a question to this outstanding lecture.
Thank you so much, Sergio. And Stanley, nice to see you again. It is extraordinary what you have just presented as a sort of breaking news, the platelet factor 4, its upregulation, and that it inhibits angiogenesis, as we know. I'd asked previously about shockwave therapy and low intensity shockwave. It has been used for diabetic feet. It has been used for erectile dysfunction. It has been used for wound healing. And the principle of shockwave therapy has always been that it creates angiogenesis. And now we have suggested that there might be some link in improving lymphedema or lipedema. And you are looking at the other end of it, saying that platelet factor 4 inhibits angiogenesis and therefore leads to, I don't know if we have struck upon a link of why ESWT probably works. And I would be really grateful if your team would be able to look at it, since you have both the molecular as well as the research facility to take this on. Because out of nowhere, there appears to have been a link from an abstract finding in our clinical practice and the wonderful molecular research that you do. So thank you so much.
Well, thank you. That's a wonderful suggestion. And of course, I'm a big believer in understanding pathophysiology as a way to intelligently guide treatment and diagnosis as well. And so it would be wonderful to find this link that will then allow for a greater exploration of things that work on an empiric basis.
So thank you again for this academic contribution. We will post the link you share, Stan, on our website. So whoever is interested, just visit the website. You will find the link over there. 15 minutes of academic time are over. I always try to put academics together in this initiative together with Professor Bottini and Professor Chi. So these will be their final remarks on the evidence-based data we have tried to provide during these 12 webinars. Oscar?
Okay. I want to especially thank each and every one of those who have been part of this incredible project that has exceeded our expectation, not only for the number of attendees, but also for the degree of commitment and quality provided every shared Sunday. Also thanks to each family to every Sunday allowed us to enter their homes and gave us their time to be able to offer some science. Finally, to Sergio and Willie, with whom we made possible to bring some relief to population in need with this incredible initiative called Food for Vein, Vein for Food. And you will always find me working for education. That is, we invite you to continue this initiative with the so-called LATAF, a true scientific bridge that will connect continents on both sides of the Atlantic bridge between Africa and Latin America. Therefore, see you soon. Thank you very much.
Thank you, Oscar, also for having birthed one of the next surprises I was going to give, but that's being part of a family, so it's totally perfect. So now, Willie.
Well, thank you, everybody. 3 months ago, you guys were just colleagues, but throughout this last 3 months, you guys became friends, and now we're all family. And thank you all for bearing through with us. And I consider you as my personal brother and sisters. Although we will not meet next week, but I'm pretty sure that the We Win Foundation with me, Sergio, and Oscar will provide more in-depth educational and research venues for all of us to enjoy throughout the world. And I will look forward to see you all in webinar again, but also in person in Dubai and our next future meetings. Thank you.
Thank you so much, Willie and Oscar. You have been, as always, incredible family members and colleagues as well. So some surprises and a final present, hopefully appreciated by all of you. First of all, deeply thank you to today's keynote speakers also for the time they will spend during this week to answer to all the questions we have received. We are for sure more than 1,000 people following today. So all the questions will have an answer. Deeply thank you to all the ones involved in this global effort. We have been able to raise so far $12,530. Part of them are already going on food projects. The final report will be delivered during World Food Day on October 16. So the project is still open and we are available if you want by email for all the details. Surprise, 6 surprises to go. So in life, it's not just where you go, it's who you are traveling with. So looking forward for the next trips together. The next evidence-based data that got our attention is this publication showing that up to 40% medical websites are including fake news. It's our responsibility as societies, I think, to work together to limit this fake news. And for this, we deeply thank the opportunity of the World Expo to gather all together, connecting experts to inform properly patients. We are already working on a Delphi consensus and everybody can visit the website of the foundation reporting eventually encountered fake news in venous and lymphatics. I deeply thank all the 70 societies already involved in this group effort. The next step forward will be with projects dedicated again to global teamwork in educations. But first of all, I like to congratulate the African, Latin American, and Asian friends who are gathering together for joint projects. And some awards are always welcomed in these global initiatives. And so the Best Question Awards goes, of course, to Wasila Taha, our Cleopatra, that also today demonstrated to be the best question in terms of ranking. And so Together with her, we will have also the Active Engagement Award for the ones who also spontaneously joined this teamwork in the person of Lorena Grillo. Now, because these two wonderful ladies and professionals are, of course, extremely experienced, and we truly believe in educating also the new generations, first of all, they will be the chairs of the committee dedicated to the selection of the 3 awards for under 35 years old who will win free registrations and accommodations to the BWinter Dubai meeting. But then again, 2 surprises to go. In life, it's not where you go, as I said before, it's who you're traveling with. As always, nothing would have been possible without professionals and here, friends of ours who we usually don't see. So my first thank goes to Erika Menegatti, the wonderful PhD behind all these projects, with a support that is more than 360 degrees, is 375, I would say. Nothing would have been possible without a guardian angel named Gabriela Sfarcic from Latin America, with interaction from Latin America. Our dear friends Carlo and Chiara for the web support. Spontaneous support coming from a special friend of ours, Joan Valdivieso Chunga, who was with us also during the humanitarian missions of BWin. And once again, Lorena and all the Latin American friends who have gathered together in a truly Pura Vena project, I hope. Again, nothing would have been possible without the ones we usually don't see, but are truly present. Professionals that now I call also dear friends, like Khaled, who is now a friend of all of us. And since I will not be able to say now, see you next Sunday, on behalf also of Willie and Oscar, I will ask Khaled to play a video that we have thought to give to you as a present, as a memory that will remain in the most precious part of our heart, as all of you will remain in our heart for your special contribution and teamwork. So please, Khaled, the mic is not anymore with me, but it's with you. And please, I wish you all the best. I say hi, and I wish you to enjoy the video we are going to project as final part, and we will send the video to all the faculty. Khaled, play the video, please, and thank you again, everybody. Three, 2, 1, and welcome everybody again to Food for Veins and Veins for Food.
All the best possible.
Today's initiative, wonderful initiative, Foods for Veins and Veins for Food starts with a mission to join efforts in such important field.
Les recuerdo a todos que pueden hacer sus preguntas en el chat en español.
Good morning, good afternoon, good evening, and let's enjoy the show again. 各位同道们，各位朋友们，大家早安、午安、晚安。
I was getting bored because she wasn't appearing yet, but now we have her on podium again, our Cleopatra of Fleboggi, Wasila Taha.
And then before I finish, I'm sorry for this, I can't help myself. Dr. White, bravo, bravo, bravo. The investigators, oh, and bravo to the Japanese. What a fantastic presentation. You know, I'm sorry, I'll stop now. Thank you very much.
My congratulations for you, dear publisher. Your presentation was excellent. My question is...
Deeply thank to all colleagues that have embraced the cause.
Will it?
Yeah, I'll be sure when the good morning, good afternoon, good evening. See you next week.
Thank you so much for being so operative. Thank you so much to all the ones involved in this group effort.
I really look forward to meeting you all in Dubai next year. I would be honored to host you in the Italian pavilion.
Give me peace on earth, give me light, give me life, keep me free from birth, give me hope, help me cope with this heavy load, trying to touch and reach you with
Well, we were expecting to have people disappearing, but we are still more than 300. So thank you for having remained really until the end. And next time, let's hope to be in person or as soon as possible to catch up online. Thank you again deeply. Bye.